Assalamualaikum and hi everybody. I'm going to introduce to you this orthodontic examination and diagnosis form. So this END form has 4 pages of END clinical record that you have to fill in, and then another 2 pages of consent form that you have to fill it in before you can treat any patient. In the END form, you have patient's detail, extraoral examination, intraoral examination, radiographic finding, and then all the summary and all the treatment plan. And the last 2 pages is for consent in terms of the treatment consent, and then photograph consent, and then for charges. This is the first section of the END form. In this section, you have to write patient's detail, the name, registration number, and your name. And then you have to write all this detail. In this section of patients or parents' chief complaint, you have to write their complaint in their own words. For example, if patients complain of gigi jongang, then you have to write gigi jongang here. For past medical history, as usual, you have to write any medical history that patient has and any relevant to orthodontic, for example, congenital heart disease, infective endocarditis, bleeding disorder, for example, if you want to refer for extraction. And because orthodontic deals with a lot of metal, so allergies to nickel is important to note down, and any medication that patient takes. For past dental history, you have to note down any oral hygiene habit, trauma history of patient, especially patient with increased overjet, or any family history of orthodontic problem, for example, hypodontia or maybe infected canine. And lastly, you have to note down the patient attitude towards treatment, whether the patient keen or not keen, or it is because parents request.
Now let us look at the extraoral examination. It involves 3 different planes, which are anteroposterior, vertical, and transverse assessment. Anteroposterior assessment will determine the skeletal pattern of the patient. Skeletal pattern is an assessment of maxilla and mandible in relation to the skeletal base. Skeletal pattern can either be skeletal 1, 2, or 3. There are 2 ways to assess the skeletal pattern. First, ensure that the patient sits upright in the natural head position and the lips and upper and lower lip is relaxed. It is important to assess in the natural head position as it is a standardized, reproducible head orientation. The tilt of the head can actually influence the skeletal pattern. First of all, you need to drop an imaginary line vertical from the bridge of the nose, which is the soft tissue nasal. So this line has to be perpendicular to the Frankfurt horizontal, which is an imaginary line from the inferior border of the orbit to the upper border of the external auditory meatus. This vertical line is called the zero meridian line, and it represents the anterior limit of the cranial base. So, for this zero meridian line, you have to look at the soft tissue A point, where it should lie 2 to 3 millimeters ahead of this line, and the soft tissue B point should lie 0 to 2 millimeters behind the line. So in this patient is a skeletal 1. So, the second method, you need to palpate the anterior borders of the maxilla and mandible using the index and the middle finger. The index finger represents the soft tissue A point, and the middle finger represents the soft tissue B point. So you palpate the soft tissue A and B point as so. For skeletal 1, the middle finger should be 2 to 3 millimeters closer to the patient than the index finger. For Scleral 2, the middle finger is 4 millimeters or more close to the patient than the index finger. And for Scleral 3, the middle finger is less than 2 to 3 millimeters closer to the patient than the index finger. In this patient, we can see that he is, again, a Scleral 1.
Vertically, there are two assessments. First is Frankfurt-Mandibular Plane Angle Assessment, and number 2 is Lower Anterior Face Height Assessment. For Frankfurt-Mandibular Plane Angle Assessment, first ensure that the patient is in a natural head position. Then take a ruler, identify the Frankfurt plane. Frankfurt plane is a line from lower border of the orbit to the upper border of the external auditory meatus. And then identify the mandibular plane by placing a ruler at the lower border of the mandible. So if the two lines intersect anterior to the occipital region, the Frankfurt-Mandibular Plane angle is high. If the Frankfurt-Mandibular Plane angle intersects at the occipital region, it is average, and if it intersects behind the occipital region, it is low. Now let's look at lower anterior face height assessment. First, split the face into thirds from trachyon, glabella, subnasale, and soft tissue menton. Ideally, the height of the midface and the lower anterior face height should be equal. So, what you can do, take a ruler, place the ruler from subnasale and mark the soft tissue menton. And then place this ruler on the midface, okay, and compare it to the height of the midface. As you can see, the lower anterior face height is high because the height is taller than the midface. Transverse assessment is carried out to identify whether there are any significant facial asymmetry. So first, ensure that the patient is lying in a supine position on a dental chair and examine anteriorly by looking down on the face. To construct a facial midline, so take a ruler and place the ruler vertically from nasion via the tip of the nose and the middle part of the upper lip at the Vermilion border. So, chin point should be coincident with this line. If there is a significant facial asymmetry, so identify whether it is to the right or to the left and record it in millimeters. So in this case, as you can see, that the chin point is to the right by about 2 millimeters. Facial asymmetry is usually associated with canting. So to assess canting, take a ruler and ask the patient to bite the ruler, okay, and then determine whether there is canting. So if you see in this case, the ruler is slightly shifted upwards on the right and is slightly shifted downwards on the left. So that means there is canting.
Assessment of sound and pain on TMJ can be done simultaneously. Palpate the TMJ. Ask the patient to open and close his mouth several times. Assess for any sound and ask the patient if there is any pain during this movement. Note it down in your END form. Mandibular movement. Ask patient to open and close his mouth several times. Pay attention to the jaw movement during opening and closing. Note down if there is any deviation of the jaw during this movement.
For soft tissue examination, we will look at the nasolabial angle. Assess the nasolabial angle. Determine whether it is acute, average, or obtuse. Nasolabial angle is an angle connecting the base of the nose to the upper lip. Estimate the angle. Average should be 90 degrees. If the angle is less than 90 degrees, means nasolabial angle is reduced than normal, then we record it as acute. If the angle is more than 90 degrees, which is increased than normal, then we record it as obtuse. Second soft tissue examination is looking at the lips during resting position and habitual posture. During resting position, check competency of the lips. At this time, the patient should be unaware of your assessment, then he will be in a relaxed position. So it can be either competent or incompetent. For habitual posture, some patient has tendency to have different lip posture. Example, in class 2 division 1, patient has the habit of closing the mouth. Look at this patient. Because we are looking directly at her, she has this tendency to close her mouth. But when she was unaware of a dentist looking at her, her lips will be in a fully relaxed position. This is what we call habitual posture. So we note down the difference here as in meeting or separate. Further assessing the lips, we will look at the upper lip length and the upper incisal show. For the upper lip length measurement, measure the length of the upper lip from the base of the nose to the most inferior border of the upper lip at midline in millimeter. For upper incisal show, measure the upper incisal show during resting and smiling, also in millimeter.
To the upper incisor coverage, this is to determine the amount of lower lip coverage on the upper incisor. Retract slightly the upper lip. See the level of the lower lip covering the upper incisor. Record it as 1/3, half, 3/4 or full as assessed from incisor edge. Note it down in your END form. For assessment of the tongue, you need to pull the lower lip slightly. Ask the patient to swallow. See the position of the tongue during swallowing. Patients with anterior open bite usually have to bring their tongue forward, that is thrusting, to get an oral seal before they can swallow. To assess for lisping, ask patient to pronounce words that contain few letter S. For example, Mississippi, Selasa. Listen carefully during the pronunciation. Note for any obvious lisping. For assessment of habit, ask patient or guardian regarding habits such as thumb sucking and usage of pacifier. Note the age of start, duration, that is hours per day, and also the frequency.
In this last section of others, note down any other soft tissue abnormalities such as craniofacial syndromes or cleft lip and palate.